Hemophilia and rare bleeding disorders. 2007 Advanced Emergency and Acute Care Medicine Conference, Atlantic City, New Jersey, September 24, 2007. Edward P. Sloan, MD, mile/per-hour face, Professor, Department of Emergency Medicine, University of Illinois College of Medicine, Chicago, Illinois. 54. 1. 54. Attending Physician, Emergency Medicine, University of Illinois Hospital Our Lady of the Resurrection Hospital, Chicago, Illinois. 54. 1. 54. Disclosures Novo Nordisk grant to conference. Fern Chairman and President. Fern grants from Novo Nordisk. No financial disclosures. E-medicine source materials. Slide materials from Novo Nordisk. 54. 2. 54. www.fern.org. 54. 1. 54. Global objectives: maximize patient outcome. Utilize healthcare resources well. Optimize evidence-based medicine. Enhance ed practice. 54. 2. 54. Sessions objectives: learn about hemophilia and RBDs. What are the diseases? How do patients present? What are management principles? What specific therapies? How to enhance PT outcomes. 54. 2. 54. Case presentation: 17-year-old presents to ed known hemophilia A. Fell off of bicycle. Abdominal trauma. Hypotensive, tachycardic. Abdominal tenderness. What do you do? Ed bleeding disorder patients, key concepts. Identify the bleeding disorder. Establish if bleeding is present. Treat the bleeding. Treat the bleeding disorder. Establish endpoint for Rx success. Disposition based on DX, Rx, risk. Background: rare disorder, affects fewer than 200,000 Americans. NIH Office of Rare Diseases. Hemophilia. Other bleeding disorders. Rare bleeding disorders. Disease states. Hemophilia congenital deficiency of factor VIII, Fa. Hemophilia B, Christmas disease. Congenital deficiency of factor IX, Fax. Hemophilia. Insufficient generation of thrombin by Fa and Fixie complex through the intrinsic pathway of the coagulation cascade. Fibrin clot structure. Hemophilia A. Normal clot structure. Hemophilia severity based on procoagulant levels or bleeding severity. Severe, less than 1% clotting factor present. Moderately severe, 1 to 5%. Mild, 5 to 40%. Clinical bleeding severity may not match amount of deficiency. Other inherited bleeding disorders. Congenital factor deficiencies. Von Willebrand's disease. Other congenital platelet disorders. Glanzmann's thrombasthenia. Bernard-Soulier syndrome. Von Willebrand's disease. Autosomally inherited bleeding disorder, mucocutaneous. Deficiency or dysfunction of the protein termed von Willebrand factor, VWF. Primary hemostasis is impaired. Defective interaction between platelets and the vessel wall. Factor VII deficiency. Fewer than 200 cases of true factor VII deficiency have been reported. Gene mutations, protein dysfunction. Factor VII coagulant activities measured in the laboratory are not well correlated with bleeding manifestations. Acquired bleeding disorders. Vitamin K deficiency. Severe liver disease. Factors 2, 7, 9 and 10 are decreased. Platelets dysfunctional. renal disease, platelet dysfunction, acquired bleeding disorders, oral anticoagulant therapy, prolonged use of antibiotics, develop antiplatelet antibodies, vitamin K deficiency, acquired inhibitors, antibodies, post-malignancy, related to pregnancy, idiopathic, elderly, emergency department evaluation, patient demographics. Hemophilia present in childhood, ESP with greater disease severity. All races. X-linked, recessive males. Patient presentations. Maniksai et al. Blood 2004 104, 1243 to 1252. History. What is the bleeding disorder? VWD, hemophilia AB, other factor deficiency or platelet disorder. History. What is the severity of the factor deficiency? Severe, less than 1% factor present. Bleed spontaneously and often, for example weekly. Moderate, 1 to 5%. Can have spontaneous bleeding but less frequent, for example monthly. Mild, greater than 5%. Bleed only when hemostasis is challenged, for example trauma and surgery. History. Do they have an inhibitor, a SOC with congenital factor def? What is their HIV/hepatitis status? How is the bleeding disorder being treated? When was your most recent treatment or infusion? Are you taking other medications? Hemorrhage history. General, weakness and orthostasis. Musculoskeletal, joints, tingling, cracking, warmth, pain, stiffness, and refusal to use joint, children. CNS, headache, stiff neck, vomiting, lethargy, irritability, and spinal cord syndromes. Hemorrhage history. GI, hematemesis, melena, frank red blood per rectum, and abdominal pain. Genitourinary, hematuria, renal colic, and post-circumcision bleeding. Hemorrhage history. Other, epistaxis, oral mucosal hemorrhage, hemoptysis, dyspnea, hematoma leading to airway obstruction, compartment syndrome symptoms, and contusions, excessive bleeding with routine dental procedures. Physical exam. General hemorrhage signs. Organ-specific hemorrhage signs. The astonishing results. Physical exam. General hemorrhage signs. Organ-specific hemorrhage signs. Hepatitis signs. Infections signs. Medical alert bracelet. Wallet. Performance improvement. Physical exam. General hemorrhage signs. Organ-specific hemorrhage signs. The astonishing results. Physical exam. General hemorrhage signs. Organ-specific hemorrhage signs. Hepatitis signs. Infections signs. Medical alert bracelet. Wallet, hemophilia treatment center card. Performance improvement, laboratory testing. CBC, HB, platelets, WBC, PT, UPT. VWF AG, von Willebrand factor antigen. Rice and company factor. Measures VWF activity to identify qualitative VWF disorder. Factor coagulant activity. For example 8:C, 9:C in hemophilias. Bleeding time, lab results for bleeding disorders. Prolonged PT. Prolonged UPT. Prolonged PT and UPT. Inherited disorders. FOV deficiency. VWF type 2 and 3. FI, FIX, FXI or FXI deficiency. FI, fibrinogen, FV, X or a combined factor deficiency. Acquired disorders. FOV inhibitor. VTK deficiency. Liver disease. Warfarin use. Inhibitor to FI, 9, 11, 12, VWF. Heparin use. direct thrombin inhibitor, inhibitor to fibrinogen or FV or X, liver disease, DIC, combine heparin and warfarin use, laboratory testing, PT, extrinsic, should be normal unless FUB deficiency or acquired. UPT, intrinsic, elevated in moderate hemophilia disease severity. Other red testing extremities raise head CT abdominal CT. Tests for increased compartment pressures. Nuclear bleeding studies. Emergency department management. Initial management: treat the patient. ABCs: direct hemorrhage control. Hemodynamic support. Crystalloids. Blood products. Specifically assist hemostasis, the three phases of hemostasis. Primary hemostasis. Vasoconstriction. Platelet adhesion. Platelet aggregation and contraction. Secondary hemostasis. Activation of coagulation factors. Formation of fibrin. Fibrinolysis. Activation of fibrinolysis. Lysis of the plug. Blood vessel and endothelium. Hemostasis requires and involves various physiological components. The blood vessel wall. Endothelial cells. Subendothelial tissue. Smooth muscle cells. The components of blood. Platelets, thrombocytes. Coagulation, clotting, factors. Fibrinolytic/anticoagulant proteins, primary hemostasis, vasoconstriction. The first response to endothelial injury is the constriction of the damaged vessel, which reduces the blood flow at the site of injury. Coleman R.W., et al. Overview of hemostasis. In Coleman R.W., Hirsch J., Marta V.J., Close A., George J. N., eds. Hemostasis and Thrombosis, Basic Principles and Clinical Practice. 4th ed. Philadelphia, Pennsylvania, Lippincott, Williams and Wilkins, 2001, 3-16. Primary hemostasis, formation of a platelet plug. The exposure of subendothelial components such as collagen promotes platelet adhesion. The adherence of platelets to the subendothelium leads to platelet activation and the formation of platelet aggregates, platelet plug. Coleman R.W., et al. Overview of hemostasis. In Coleman R.W., Hirsch J., Marta V.J., Close A., George J. N., eds. Hemostasis and Thrombosis, Basic Principles and Clinical Practice. 4th ed. Philadelphia, Pennsylvania, Lippincott, Williams and Wilkins, 2001, 3-16. Monroe D.M., Hoffman M. Arteriosclerothrombin Vasc Bio 2006, 26-1, 41-48. Secondary hemostasis. At the site of vascular injury, binding of endogenous factor 7/VIIA to tissue factor, TF, leads to the generation of small amounts of thrombin. Thrombin activates platelets and additional coagulation factors, which subsequently generate large amounts of thrombin. This thrombin burst induces the generation of a hemostatic plug that prevents further blood loss. Hoffman M., Monroe D.M. Throom Hemos 2001, 85-6, 958-965. Monroe D.M., et al. Blood coagulation fibrinolysis 1998, 9 Supple 1, S1520. Monroe D.M., Hoffman M. Arteriosclerothrombin Vasc Bio 2006, 26-1, 41-48. Adapted from Hoffman M. et al., 2001.1, How a Blood Clot Forms, Step 2. PTT. HMWK, Park. PT. 12. 11. TF. 9. VIIA/TF. 7. VIA. X. X. VA. IA. Thrombin. 2. Prothrombin. Fibrinogen. Fibrin. Clot. Factor I. Platelets, clotting factors, coagulation cascade. What is broken? Platelets. Clotting factors. Coagulation cascade. What can be provided? Vitamin K, FFP, fresh frozen plasma. PCC, prothrombin complex concentrate. Platelets, packed RBCs, whole blood. Specific clotting factors. Antifibrinolytics, antihemophilics. Hemophilia A, factor VIII. Recombinant factor VIII concentrate is the preferred source of factor VIII. The factor VIII activity level should be corrected to 100% of normal for potentially serious hemorrhage. Units: factor VIII equals weight in kg 50 ml plasma /kg 1 U factor VIII per milliliter plasma. Desired factor VIII level minus the native factor VIII level. Hemophilia A, factor VIII. As an example, an 80 kg individual diagnosed with hemophilia with known 1% factor VIII activity level presents to the ED with a severe upper GI bleed. Units: factor VIII equals 80 kg 50 ml /kg 1 U factor VIII per milliliter 0.99 equals 3960. Hemophilia A, factor VIII. Next dose, 12 hours later, half initial dose. Minor hemorrhage, 1 to 3 doses factor VIII. Major hemorrhage, mini doses, continued factor VIII activity monitoring. Goal: trough activity level at least 50%. Hemophilia A, other Rx FFP, administer 1 ml for FFP/U factor VIII. Antifibrinolytics. Epsilon aminocaproic acid, amicar. Oral mucosal bleeds, rich fibrinolytic activity. 200 mg/kg PO/4 initial dose. 100 mg/kg Q6H, not to exceed 5 grams. Alternatively, 10 grams slow 4, over 2 hours, followed by 1 gram/H continuous infusion. Hemophilia A, other Rx anti-hemophilic agent. 1-deamino-8-D-arginine vasopressin, desmopressin acetate, DAVP. Increase, up to 4-fold, in Phe plasma levels. 0.3 micrograms/kg in 30 to 50 ml. 0.9% isotonic saline for over 15 to 20 minutes. Not indicated in platelet type VWB. Hemophilia B, factor IX. Synthetic recombinant factor IX. Units: factor IX equals weight in kg 100 ml/kg 1 U factor IX per milliliter. Desired factor IX level minus the native factor IX level. Hemophilia B, factor IX. As an example, an 80 kg individual diagnosed with hemophilia with known 1% factor IX activity level presents to the ED with a severe CNS bleed. Units: factor IX equals 80 kg 100 ml/kg 1 U factor IX per milliliter 0.99 equals 7920. Hemophilia B, factor IX. Next dose, 12 hours later, half initial dose. Minor hemorrhage, 1 to 3 doses factor IX. Major hemorrhage, mini doses, continued factor IX activity monitoring. Goal: trough activity level at least 50%. Hemophilia B, factor IX. Factor IX complex concentrates. Coagulation factor IX concentrates, pooled plasma product, high purity. Hemophilia B, other Rx FFP, administer 1 ml for FFP/U factor IX. Antifibrinolytics. Epsilon aminocaproic acid, amicar. Oral mucosal bleeds, rich fibrinolytic activity. 200 mg/kg PO/4 initial dose, 100 mg/kg Q6H, not to exceed 5 grams. Alternatively, 10 grams slow 4, over 2 hours, followed by 1 gram/H continuous infusion. VWDX, Platelet activation. Resting. Activated. 50,000. Greater than 500. Fibrinogen. Granules. P-selectin. Haemophilia. Haemophilia. P-selectin. PIV. PIV/9/V. PIV/9/V. PIV. Activation. 25,000. PIV9V, internalized. Haemophilia. 1. Membrane expression increased. 2. Complex occupied by fibrinogen, von Willebrand factor. P-selectin, translocated to the membrane. Von Willebrand's disease Rx. Anti-hemophilic agent. Type 1 VWDX. 1-deamino-8-dearginine vasopressin, desmopressin acetate, DAVP. Up to 3 to 6-fold increase in Phe and 2 to 4-fold increase in VWF plasma levels. 300 micrograms intranasally produces levels comparable to 4 infusion. Useful for menorrhagia and epistaxis. Von Willebrand's disease Rx. Platelet transfusions if other Rx not effective. Cryoprecipitate, FFP contain functional VWF, not used widely. Rare bleeding disorders. Congenital factor deficiency of any of the following: 7, 11, X, 2, V. Combined 5 and 8. Fibrinogen. 13. Phi 1. Congenital platelet disorders. Glanzmann's thrombocythemia. Bernard-Soulier. Von Willebrand's disease, types 2 and 3, rare bleeding disorders, Rx. Stabilize the patient. Call the hematology/oncology consultant. What can be provided? Specific clotting factors. PCC, other concentrates. Antifibrinolytics, antihemophilics. FFP, 1 ml per unit of clotting factor. Platelets. Patient outcome: low HB, ruptured spleen IVF, cross-matched blood. 10% factor 8 levels prior. Units: factor 8 equals 70 kilograms 50 milliliters/kg, 1 U factor 8 per milliliter 0.90, equals 3,500. Stable to ICU with expectant management. Conclusions: complex medical problems, lumpers and splitters. Treat the patient's hemorrhage. Identify the disease. Treat the disease, as able. Consult liberally. Admit as indicated.